Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to John Donoghue about the extraordinarily high death rates in schizophrenia and what we might do about them. John, could you start by introducing yourself?
My name is John Donoghue, and I am a consultant mental health pharmacist.
And can you give us a brief overview of what your current role involves?
I work as a freelance, and I work with a range of organizations. Most of my work concerns medical education, but I also work as a consultant with mental health trusts and pharmaceutical companies. And my main interest is severe mental illness, and in particular, schizophrenia. So I offer insights and advice and education on the management of severe mental illnesses. I also do some outcomes research. I was one of the very early researchers in the UK to start using large data. I was using large data back in the 1990s before most people had even thought of it. And I don't really take credit for that. It was entirely accidental. I was working for what was then Liverpool Family Health Services Authority. And I encountered PACT data for the first time. And I discovered that PACT data could be analyzed by postcode. And I thought, oh, there's a useful tool, because if you consider that medicines can be used as a proxy for disease, you can then map disease by postcode. So that's when I started my interest in big data and in outcomes research. Unfortunately, the Department of Health at that time were not inclined to cooperate. And they said, because I wanted to think about how you could expand on this as a very useful public health tool. And the Department of Health said, well, PACT was never designed for this, so we're not going to support it. Thank you very much and goodbye. So that was that. And I've done outcomes research in major depression, in sleep disorders, in dementia, and in schizophrenia. And as I said, my main work is creating and delivering educational packages to address shortfalls, I suppose, in the care for people with severe mental illness. And these packages have been used both in the UK and internationally.
I'm aware that you've devoted much of your career to mental health. Could you tell us briefly what first sparked your interest and how you got started in this area?
I started my career in community pharmacy. And at one point, I was the owner or co-owner of 3 pharmacies, all of them purchased with very large bank loans. And though I enjoyed the work, because community pharmacy does give you a lot of opportunity for interacting with patients, I always felt there was something missing. There was something that wasn't challenging me. I didn't really feel any vocation for community pharmacy. I think, like many pharmacists, I went into it because that was the thing to do after you finished your degree. And I have to say, the amount of money that I owed the bank was giving me sleepless nights. And then here I'm going to reveal my age. Back in 1991, an opportunity came up to work in mental health. I, at the time, was the chair of Liverpool LPC. And so I was in close contact with the people at the FHSA, and they said that they had just been awarded a project by the Department of Health, which was a pilot project aimed at community mental health care. And they wanted to explore the idea that community pharmacies could provide various aspects of mental health care. So not because I had a particular interest in mental health, but because of my contacts in community pharmacy, I applied for the job as manager of the Liverpool arm of the project. The other arm was Nottingham, and was given the job. And to my surprise, I was given the job because I thought there must be mental health pharmacists out there with a lot more expertise than I had, who'd applied for the job. But anyway, once I got into it, I just found mental health was utterly fascinating and very challenging. And it challenged me in ways that fed into what I thought what pharmacy could and should be. Because I have felt for a long time, and even before I started this project, I was going to the consultant pharmacist meetings in the US and seeing what consultant pharmacy was in the US and thinking, why aren't we doing that in the UK? I didn't want to be paid for putting tablets in bottles. I wanted to be paid for my knowledge, my experience, and the advice that I could give. And here was mental health pharmacy, where all those opportunities were open before me. So the project was a 2-year fixed term contract. It was very successful. I won a pharmaceutical care award on the basis of what we did. And at the end of it, I was faced with the prospect of going back to community pharmacy, which after the sheer almost exhilaration of working in mental health didn't appeal anymore. So I sold the pharmacies, got rid of the bank loans, which was wonderful, and started work as a clinical mental health pharmacist at Clatterbridge Hospital in the Department of Community Psychiatry. And I've never looked back and never regretted that decision.
You are the founder of a company, Medicines in Mental Health, an independent health sector provider. Could you tell us a bit more about this?
But I founded it because I needed a vehicle to help me to manage and promote my work. And it also gives me an online presence. And as my website says, my aim is to improve outcomes for some of the most vulnerable patients in healthcare. And that's it, really.
A recent systematic review looked at mortality in people with schizophrenia. It looked at relative risk and also aggravating and mitigating factors, and came up with findings that at the very least call into question the current NICE guidance. I want to get to this, but I'm hoping that you can give us a primer on mortality in schizophrenia first. Could you remind us briefly what schizophrenia is?
What I could perhaps just say is schizophrenia is the most important psychotic disorder in psychiatry. And it's characterized by a lifetime of illness in which the patient experiences periods of remission interspersed with relapses and a gradual decline in their intellectual and social capacity over the years.
And now let's move on to premature mortality amongst people with mental illness and schizophrenia. First, how big a problem is it? And could you put some numbers to it for us?
Okay, I always like to start when I'm talking about schizophrenia with a quotation that came from the journal Nature over 30 years ago. And they had devoted an entire edition to advances in the understanding and management of severe mental illness. And there was a commissioned editorial. And the editorial characterized schizophrenia as arguably the worst disease affecting mankind, even AIDS not accepted. Now, if you cast your mind back 30 or so years ago, AIDS was this quite frightening mystery illness that was reaching epidemic proportions. People worldwide were extremely worried about it. And if you think about what's happened in the care of people with HIV in that 30 years, we've had huge resources poured in. There's been an enormous amount of research, new treatments developed, clinical practice has moved on, and now people who are HIV positive can lead practically normal lives. The same can't be said of schizophrenia. So it remains arguably the worst disease affecting mankind. And that's always my starting point with schizophrenia. I think it's important to distinguish between severe mental illness and schizophrenia, because severe mental illness is an umbrella term and could potentially include people with major depression, bipolar disorder, dementia, and so on. And many of the studies that have looked at mortality have looked at severe mental illness populations rather than specifically at people with schizophrenia. Now, one of the numbers that gets brought up time and time again is a 15 to 20 year loss of life expectancy. Now, those figures come from an epidemiological study that was conducted in Scandinavia 20 years or so ago. And this was in people with severe mental illness, not specifically schizophrenia. And what they found was, at best, which was in Sweden, there was a loss of life expectancy of 15 years in females and 20 years in males. So that's where this 15 to 20 year loss of life expectancy figure comes from. They also calculated a statistic called the standardized mortality ratio. Now, this is a standard statistic used in public health to compare mortality outcomes across a range of diseases. And it's quite simply calculated as the rate of death in the population of interest, so in this case, severe mental illness, and then compare that with the rate of death in age and sex-matched comparators within the general population who don't have severe mental illness. So the standardized mortality ratio in this study was 2 in females and 3 in males. What that means is mortality rates were twice as high in females with severe mental illness and 3 times as high in males with severe mental illness, which is a quite shocking statistic. Now, of course, that was standardized mortality rate. That was severe mental illness, not schizophrenia. If we turn to schizophrenia and to the UK, a recent large-scale study from the UK found that the mean age of death in the general population without any severe mental illness was 79 years. Now, this is in a general practice population, so it's a little bit lower than the complete population figure. But the mean age of death in schizophrenia was 66 years. Now, if we put that into some sort of context, if you imagine that people generally aspire to retire at the age of 60 these days. So on average, what that means is they'll have 19 years in which to enjoy their retirement, and jolly good luck to them. For a person with schizophrenia, on average, they won't live long enough to qualify for the state pension. That's how big this loss of life expectancy is for people with schizophrenia. Now, those figures apply specifically to the UK. There is a recent systematic review of mortality in schizophrenia, which I personally consider to be the most important study in schizophrenia for the past quarter century. This is the work of Christoph Carell, who is professor of psychiatry in New York, and his group. Now, this systematic review of mortality in schizophrenia, we'll come to the results in a minute. I want to explain why this is so important. First of all, there's the sheer size. They included both population-based studies as well as clinical trials of people with schizophrenia where mortality was the outcome. So the size of the study is they had 4.5 million people with schizophrenia compared with over 1 billion age and sex match controls from within the general population. So that's the first important aspect of this study, the sheer size of it. The second aspect is they compared outcomes in what they called incident and prevalent schizophrenia. So incident schizophrenia are first episodes, or it could also be newly diagnosed patients, even though they've had symptoms for quite some time. Prevalent schizophrenia is what we think of as chronic schizophrenia. So these are long established cases of schizophrenia. So that's the second important aspect, incident and prevalent populations. The third important aspect was they compared outcomes in schizophrenia for specific diseases. So, for example, for patients who died as a result of a stroke, mortality rates in stroke were compared directly with mortality rates from stroke within the general population. And same with other diseases, cardiovascular disease, type 2 diabetes, and so on. And then the fourth important aspect of this systematic review was they also explored mitigating factors that would reduce mortality, and we'll come to that in a few minutes. Now, the outcome measure that they used was called the risk ratio. Now, the risk ratio is calculated in exactly the same way as the standardized mortality ratio. However, it's not appropriate to use the term standardized mortality ratio when you're considering subsets of the population. So in that case, risk ratio is the more appropriate term, but it's calculated in exactly the same way. Now, what the study found was that the risk ratio for all patients with schizophrenia, for all causes of death, compared with the general population, was 2.9. So if we round that up to 3, what that means is mortality rates in schizophrenia are 3 times higher than in age and sex-matched controls within the general population. Now, of course, suicide is a particular outcome of interest in schizophrenia. And for suicide, the risk ratio was 9.8, effectively 10. So mortality rates from suicide in schizophrenia, 10 times higher than in age and sex-matched controls in the general population. For natural causes, the risk ratio was 2.2. So what that means is mortality rates from natural causes are twice as high in schizophrenia as they are in age and sex-matched controls in the general population. And those findings really ought to be a major cause for concern for public health, literally worldwide. My interest, of course, is the UK. And the concern about these mortality rates is certainly not a feature of the current NICE schizophrenia guideline.
These are shocking figures. I wonder, are they comparable with other chronic diseases?
Well, compare that with something like cancer rates, death rates from cardiovascular disease, death rates from stroke. And there is huge public concern about this. Quite rightly, don't get me wrong, I'm not decrying the public concern about those issues, but there appears to be very little concern about people with schizophrenia.
From what you've said, the reduction in life expectancy in schizophrenia is considerable. Do we know what factors contribute to this?
It's very likely that a wide range of factors contribute to high mortality in schizophrenia. If we start with thinking about the illness itself, people with schizophrenia face a range of difficulties. Schizophrenia affects people cognitively. They find it difficult to assess and assimilate information and to make choices based on that assessment of information. They may be completely unaware that they have a serious physical illness. Even if they do know they have a serious physical illness, people with schizophrenia find it very difficult to access care. Now, if you think about the difficulties that you or I face in trying to get an appointment with the GP, you make a phone call, you speak to a receptionist, they tell you you can have an appointment 3 weeks on Tuesday. And we kind of grin and bear it and we put it in our diary and we turn up 3 weeks on Tuesday. For a person with schizophrenia to be told something similar, that is a barrier. That is insurmountable to them. 3 weeks on Tuesday is an impossibility. So they don't turn up 3 weeks on Tuesday. And that is a systemic problem. They also find it difficult to engage with care. Now, we talk a lot about poor adherence to antipsychotic treatment with schizophrenia. Is if that is somehow the fault of the patients? Actually, it's not. Now, you and I know that poor adherence with medication is endemic across disease areas. But in schizophrenia, people find it much more difficult, as I've said, to assimilate information, understand information, and then act upon it. And so their lack of engagement with taking medication is probably part of the disease process. It's not just something that's inherent in, human psychology. That's particularly the case if they're having to take responsibility for some aspects of their care. So if they're having to manage turning up for tests, then going back to the GP for the results of the tests, discussing with the GP what we might do as a result of those tests. So all those are made much more difficult purely and simply by the fact that they have schizophrenia. On top of all that, people with schizophrenia often lead unhealthy lives. Obesity rates are high, and they also engage in unhealthy behaviors such as smoking and alcohol misuse. And we'll perhaps say a little bit more about that further on. Then there are factors related to the provision of psychiatric care. Now, having worked as a pharmacist in mental health care for over 30 years, I know from my own experience that certainly all the training that I've done in psychiatry has focused on mental health, not physical health. So my focus largely is on mental health rather than physical health. And then, of course, we have the prescription of anti-psychotics, which may have cardiometabolic side effects. Then there are problems with the structures of health services and the way the care is provided. And one of the key issues here is the division between mental health care and primary care. And I've already explained that people with schizophrenia may have difficulties accessing primary care, but they may also meet negative attitudes within primary care because people don't have experience of offering care to people who have an illness like schizophrenia. So patients may be fobbed off, clinicians may underestimate the seriousness of the physical illness, or it may be the case that not just the patients find it difficult to engage, but also the clinicians find it difficult to engage. Follow-up can be patchy, even non-existent in some cases. If we then come to this question of separation between primary care and psychiatric care, what we then find is communication difficulties. There are often gaps in communication, and of course patients do fall between those gaps. And there's also a lack of clarity in who is responsible for managing which aspects of mental health care. Now, as we'll come to later, we'll see the NICE guideline says primary care physicians should manage physical health care. We'll say more about that later on. Finally, even within the specialty of psychiatry, 20 years ago now, we had a process called New Ways of Working. And the New Ways of Working process was intended to create extra specialization. So we would have clinicians who specialized in acute care, clinicians who specialized in community-based care, and so on. And that separation has also created difficulties. So we have fragmentation of services, we have fragmentation of medical knowledge. Patients find it difficult to navigate their way between different aspects of the service. And back in 2012, there was a major report from the Schizophrenia Commission, which was organized by a group of mental health charities. And one of the quotes that I use an awful lot from the Schizophrenia Commission report was patients saying, "I don't know who my psychiatrist is anymore." And I like that quote because it shows the gaps that patients find it difficult to jump across between different aspects of the service. So if we bring all of those factors together, it seems we have a melting pot, if you like, of adverse circumstances which a person with schizophrenia is forced to deal with. And so it's no surprise that their health should suffer and that mortality rates should be high.
Very interesting. I've read that cardiovascular morbidity is an important issue here. So does this mean that the excess deaths in schizophrenia are due to cardiovascular disease?
Certainly some of them are due to cardiovascular disease. In fact, the most common cause of death in schizophrenia is from cardiovascular disease. And the mortality rate from cardiovascular disease in schizophrenia is more than double that of age and sex match controls in the general population. But we mustn't forget suicide as an important cause of death in schizophrenia. And even if we look at cancer, the rate of death from cancer in schizophrenia is fully 1/3 higher than it is in the general population. So there are, in fact, a whole range of physical illnesses where the mortality rates are higher in schizophrenia. However, let's go back to cardiovascular disease. One of the comparisons in the Correll systematic review was to look at mortality rates from cardiovascular disease and schizophrenia and compare them with mortality rates within the general population in people who had had a myocardial infarction. Now, there you would expect mortality rates in the general population would be particularly high. However, in schizophrenia, mortality rates are 85% higher than in people who've had a myocardial infarction. If we look at other vascular and metabolic diseases, mortality rates again are higher than in the general population. For cerebrovascular disease, mortality rates in schizophrenia are about 60% higher. And in diabetes, they're about 3 times higher. Now, even when you compare the mortality rates for people with diabetes in the general population with people with schizophrenia, mortality rates in schizophrenia remain nearly 50% higher. So even when we're making that direct comparison. And what this suggests to me is really quite significant gaps in the provision of care for people with schizophrenia. And it's not just down to one thing. It could be that people with schizophrenia are not seeking care for these conditions. But it could also be that clinicians are not identifying cardiometabolic disease in people with schizophrenia or not offering appropriate levels of care. So we've got a kind of coming together again of a range of factors contributing to these high mortality rates for cardiovascular disease.
Again, arresting numbers. Could you give a concise overview of the risk factors and comorbidities experienced by people with schizophrenia and how they compare with the general population?
Well, to start, 2/3 of people with schizophrenia are either overweight or obese. Prevalence of diabetes in schizophrenia is nearly twice as high as it is in the general population. The proportion of people with schizophrenia who smoke is twice as high as in the general population. The prevalence of alcohol misuse in schizophrenia is about 3 times higher than it is in the general population. And the rate of drug misuse in schizophrenia is about 7 times higher than it is in the general population.
That sums it up very nicely. Could you say more about the cardiometabolic risks associated with antipsychotic treatment?
Many of the antipsychotics that are in the BNF are associated with cardiometabolic risks. Initially, what is seen is weight gain, but this is then followed by the development of obesity and then type 2 diabetes and all the sequelae that come from that. In my experience, I have seen these cardiometabolic risks characterized as a dichotomy between first and second generation antipsychotics. So broadly speaking, first generation antipsychotics are the older drugs like chlorpromazine and haloperidol. Second generation drugs are the newer ones, including aripiprazole, cariprazine, olanzapine, quetiapine, risperidone, and paliperidone. Now, the false dichotomy that I've seen put forward is that first generation drugs are less likely to be associated with cardiometabolic side effects than second generation drugs. And for that reason, there should be a preference for first generation drugs. The fact that they're also cheaper has got absolutely nothing to do with it. This is a complete mischaracterization because antipsychotics vary widely in their liability for cardiometabolic adverse effects. So, for example, haloperidol. Weight gain with haloperidol and BMI change with haloperidol is no different from placebo. But the same is true of aripiprazole and cariprazine and lurasidone, all of which are second generation agents. Olanzapine is associated with significant weight gain and increased risk for type 2 diabetes, but so is chlorpromazine. So what we need to do is to think about the cardiometabolic profile of each drug individually, and we use that knowledge of the individual liability to inform clinical decisions about which drug might be appropriate for a patient and how metabolic side effects should be managed.
So there are disease factors plus treatment side effects that all roll up together. Now, I understand that the NICE guidance says that healthcare professionals in primary care should monitor the physical health of people with schizophrenia or psychosis. Why is that? And is the answer to all of this just follow the guidelines better?
If only. The NICE guideline is very clear. It says that the responsibility for physical health monitoring for people with schizophrenia lies in primary care. The guideline does more than that because it also tells primary care clinicians how that care should be provided. And they refer them to various relevant NICE guidance for things like lipid modification, type 2 diabetes, obesity, hypertension, and so on. The problem here is that this is complex care, and it requires the person on the receiving end of that care to be fully engaged as a participant in care. So the patient has to make the appointment to see the GP. And we already talked about how difficult that could be for a person with schizophrenia. They then have to attend for the appointment. They're likely to be sent for various tests. They have to attend for the test. They have to go back for the results of the tests. If the GP then decides to prescribe a lipid lowering agent or an antihypertensive or whatever, the patient then has to take it. Now, we know that people with schizophrenia struggle to take antipsychotic medication. What makes us think that it's any different if they're prescribed a statin or an antihypertensive? So in my view, primary care simply was never designed to provide care of this complexity for a disease that is as complex itself as schizophrenia. And a number of mental health organizations now have taken it upon themselves to provide in-house physical health monitoring. But that provision is patchy, and it would be far better if the NICE guidance were changed, in my view, so that we had holistic physical health care provided within the mental health sector, and the mental health sector was actually resourced to provide it.
Mm-hmm. Now, I've come across the Leicester Cardiometabolic resource. What is it exactly, and would it help here?
It is a quite remarkable piece of work. And it's remarkable because it brings together, not just in one place, but on one page, all the various interventions that need to be made in order to provide care for people with whatever aspect of cardiometabolic disease exists. It is, however, very complex. And for me, that begs the question, if the answer to your problem is as complex as this is, should we not be thinking preventively? Now, the other thing about the Leicester resource is it gives you a range of interventions that you ought to make in order to provide care for people with cardiometabolic disease. But it doesn't say anything about the antipsychotic that might be contributing to the cardiometabolic disease. And neither does the NICE guideline.
That looks useful. Now, I want to come back to antipsychotics and mortality in schizophrenia. From what you said, antipsychotics can have some serious metabolic and cardiovascular effects that contribute to mortality, and yet, on the other hand, they can also exert positive effects. Can you just walk us through this paradox?
It's a complicated paradox, but put quite simply, taking any antipsychotic regularly for a person with schizophrenia is likely to reduce the risk of mortality. Now, these data come from the Correll systematic review, and these are the mitigating factors that reduce mortality rates. So if we go through the key findings on that one by one, for all patients, for all causes of mortality, antipsychotics taken regularly are associated with reduction in mortality. However, the largest effect is seen with second-generation antipsychotics when given as a long-acting injection. And with these medicines, we see a whopping 61% reduction in mortality rates. If we turn to mortality from suicide, and again, I'm considering all patients here, in reducing mortality from suicide, first-generation antipsychotics taken orally have no effect. Given as long-acting injections, there is a statistically significant reduction in mortality from suicide. But as with overall mortality, the largest effect in reducing mortality from suicide is with second-generation antipsychotics given as long-acting injections, and they're associated with a 57% reduction in mortality rates from suicide. If we turn to incident patients, now these patients are extremely important from a preventative perspective, because these are the new patients, first episode patients, and it's here that we have the greatest opportunity to prevent progression of schizophrenia and the lifelong misery that it causes. So if we think about first episode patients and all causes of mortality, first generation antipsychotics, whether given orally or as long-acting injections, have no effect in reducing all-cause mortality in first episode schizophrenia. In contrast, second generation antipsychotics given as long-acting injections are associated with a dramatic reduction in mortality rates of 85%. Now that, I think, is an extraordinary effect. But there is a reluctance in early intervention services to offer long-acting injections to first episode patients. Partly because of there's a reluctance to make a diagnosis of schizophrenia because it's felt to be stigmatizing. And partly because injections are seen as invasive and patient autonomy and choice should be respected as much as is possible. For me, that is a misguided approach, because what we see is that approach is associated with much higher mortality rates. And I do a little mind experiment, little thought experiment, when I'm talking to clinicians about this. And what I suggest to them is that we take schizophrenia out of the equation. Let's imagine instead that instead of being a psychiatrist, you are in fact an oncologist. And you have a young patient in their mid-20s, not unlike a first episode schizophrenia patient. But instead of schizophrenia, they have a potentially life-threatening cancer. And you are able to say to this patient, I have a treatment that's very effective. It will reduce your risk of an early death by about 85%. What do you think? There is a problem. We have to give it by injection. It will have side effects, but we can help to mitigate those side effects. So what do you think that 25 to 30-year-old oncology patient is likely to say to that offering? Now let's take oncology out of the equation and put schizophrenia back in. And why don't we make that same offer to younger patients with schizophrenia? Because it, in fact, is precisely the same principle. If we look at mortality from suicide in incident patients, unfortunately, there aren't enough data to draw any conclusions about long-acting injections, whether they're first or second generation antipsychotics. Second generation antipsychotics given orally are associated with a nearly 50% reduction in mortality from suicide. However, that finding was not statistically significant. First generation antipsychotics given orally are associated with a doubling of mortality rates from suicide. That finding was statistically significant. And for this reason alone, first generation antipsychotics should be contraindicated in first episodes of schizophrenia.
That's a very powerful message. And where does Clozapine fit into all of this?
Well, we talked about the paradox of antipsychotics. And no antipsychotic exemplifies this paradox better than Clozapine. Now, if we think about Clozapine, its use is limited. I'll start that again. Its use is limited to patients with the most difficult form of illness to treat, treatment resistance. And it is associated with a long list of side effects, some of which are potentially life-threatening. So we see agranulocytosis, myocarditis, cardiomyopathy, and the most common cause of clozapine-related death, constipation. The reason that it's the most common cause of clozapine-related death is because it doesn't get picked up until it's become really paralytic ileus. Despite all these problems, clozapine is associated with an overall reduction in mortality rates of approaching 60% and a halving of mortality rates from natural causes. If we look at suicide with clozapine, and remember, these are patients with treatment-resistant schizophrenia, we see a dramatic reduction in mortality from suicide approaching 80%. And in the US, this finding alone has led to an indication for clozapine for suicide prevention in patients with schizophrenia considered to be at risk of suicide. It doesn't have that indication in the UK.
I know there has been some negative press coverage about clozapine, portraying it as a toxic drug that kills people. Would you like to comment?
I deplore this ill-informed reporting in the lay press. The evidence is absolutely clear. Clozapine is a drug that saves lives. And those few words there should be printed in bold and double underlined. And this ill-advised and ill-informed reporting in the lay press is a great concern because it puts people off, especially families, from accepting treatment with clozapine when it literally could save that person's life. For patients with treatment-resistant schizophrenia, clozapine literally is a matter of life or death.
And now, why do you think antipsychotics have such a powerful effect in reducing mortality rates?
There's no hard evidence to provide a specific answer to this question. My personal view is that the protective effect is associated with better long-term mental stability. If we think about the pattern of illness in schizophrenia as one of repeated episodes of psychosis, there's a very large literature on the protective effect of antipsychotics in preventing psychotic episodes. But unfortunately, adherence to treatment in schizophrenia is very poor. This isn't because patients are making rational choices about whether or not to take the medicines. It does seem to be a feature of the illness, and in particular, negative symptoms that affect the person's ability to make decisions, to look after themselves, and to engage actively as a partner in care. It's also been amply demonstrated now that psychosis is a neurotoxic process. And there's work being done in the US, a guy called Henry Nasrallah, who has done serial brain scans of patients following serial psychotic episodes. And what they found is a measurable reduction in brain volume with each repeated episode. So what we see is a gradual but irreversible worsening of psychopathology. It also means that even the best efforts of clinicians can never restore patients to their previous level of functioning. And that's why preventing relapse is probably the single most important thing that people offering care for people with schizophrenia can actually do. So as mental health declines, the ability to look after yourself declines, the awareness of any physical health problems also declines, the need to seek help, or rather the appreciation of the need to seek help, declines. And then there are all the problems of navigating complex systems of healthcare, like the boundaries that exist between primary care and mental health services. And while all this is going on, we have problems like obesity, smoking, alcohol misuse, all raising their heads as well. So if we can improve long-term mental stability, that mitigates against all of those factors. If we now put antipsychotics into the equation, we know that failing to take antipsychotics regularly increases the risk of relapse somewhere between 3-fold and 5-fold, depending on which study that you look at. Antipsychotics taken regularly prevent relapse. And that's probably why we see greater reductions in mortality with long-acting injections. Now, for those of our listeners who are interested in the number needed to treat as an outcome measure, The number needs to treat with a long-acting injection like aripiprazole or paliperidone at 1 year to prevent relapse is 4. Now, for a preventative treatment, that is extraordinary. And that shows just how powerful that protective effect is and underlines precisely why we should be using more of these particularly that underlines particularly why we should be using more of these medicines. This doesn't quite explain the reduction in mortality seen with clozapine, because obviously clozapine is not available as a long-acting injection. But we need to think about the characteristics of patients who are eligible for treatment with clozapine. So these are patients who are treatment resistant and for whom their quality of life, their cognitive abilities, their social functioning, engagement with care tend to be particularly poor. Typically in the UK, they will have received at least 5 different antipsychotics before receiving clozapine, despite what the guideline says. Now remember, these are 5 antipsychotics that didn't work, but did cause side effects. So you can imagine what the attitude to treatment is among these patients. Clozapine, though, in a lot of patients, delivers a really remarkable degree of improvement. Nobody knows why. It's still a mystery. I suspect that the person who finds out why clozapine is better will get a Nobel Prize, but that's a different conversation. It's a very powerful effect psychologically for the patient. They're very aware of the improvement in their quality of life since they started taking clozapine. And there have been a number of patient surveys in patients being treated with clozapine which show very high levels of patient satisfaction. And patients typically saying they would rather continue with clozapine despite all the side effects than go back to their previous medication. So the upshot of all of this is that adherence rates with clozapine are very much higher than with other oral antipsychotics. And this is what contributes to the long-term improvement in their mental state. And that's what I think explains the reduction in mortality seen with clozapine.
And next logical question, why do you think second-generation agents have better outcomes than first-generation agents?
This is a very complex question and unfortunately requires a complex answer. Outcomes with second-generation agents are generally better than with first-generation agents, but it's due to a number of factors. To start off with, second-generation agents are more effective than first-generation agents at preventing relapse. There's a systematic review of relapse prevention that found that relapse rates with the second-generation agents were significantly lower than with the first-generation agents, and the lower relapse rates were observed at every time point. So at 3 months, 6 months, 12 months, and at study endpoints. So that's aspect number 1. The second aspect is to do with long-acting injections. And patients who receive treatment with second-generation or first-generation long-acting injections, those on second-generation agents, persistence with treatment is nearly twice as high at 2 years compared with first-generation agents. And that pattern is consistent across age groups. So in younger patients, middle-aged patients, and also older patients. So if my hypothesis, if you like, that the reductions in mortality rates are associated with better long-term mental stability, then taken together, these findings offer a plausible explanation for why the greatest reductions in mortality rates are seen with second generation antipsychotics, particularly when they're given as long-acting injections. Now, there are a number of influential voices in the UK who completely disagree with all of this and insist that we should continue to use first generation agents. And I can find personally no reason for them to be saying this apart from the fact the first generation. I can find no reason apart from the fact that first generation agents are cheaper, which shouldn't be an issue because nearly all of the second generation agents are now available generically. There is another factor, and that other factor is that second generation agents appear to be neuroprotective. Now remember, we found that psychosis is a neurotoxic process. So if we have something that's neuroprotective, that's actually very valuable. And there are two systematic reviews in the literature, one of first generation agents and one of second generation agents. Now the systematic review of first generation agents was only able to find evidence related to 3 antipsychotics: haloperidol, fluphenazine, and perfenazine. But what they found was that each of these agents had no neuroprotective effects. In fact, they were neurotoxic. So that maybe explains some of the difference between first and second generation drugs. In the second systematic review, a range of second generation agents were investigated for neuroprotective properties. And I'll give you a list because these were included in the review: aripiprazole, Clozapine, lurasidone, olanzapine, paliperidone, quetiapine, and risperidone. So this isn't a one-off effect of one particular drug. And what they showed were multiple neuroprotective effects, including reductions in oxidative stress, reduced myelin loss, and protection against apoptosis. So a clear differentiation there between first and second generation drugs. And I think all of these findings about better relapse prevention, better persistence with treatment, neuroprotection with second generation agents, they're all consistent. And they're also all consistent with the finding that second generation agents given as long-acting injections are associated with the greatest reductions in mortality. My view, second generation antipsychotics should invariably be first choice treatments for all patients with schizophrenia.
Very interesting. What conclusions can be drawn from the findings that you've described?
I think there's one inescapable conclusion. We have compelling evidence of the superiority of second generation antipsychotics given as long-acting injections. The conclusion that I draw from it is that these medicines should be first-line treatments for all patients with schizophrenia, apart from those who are eligible for treatment with Clozapine.
So what are the bottom lines for practitioners? What should they be doing?
There should be a presumption that the treatment for any patient, whether they're a first episode patient or a chronic schizophrenia patient, there should be a presumption that first-line treatment will be a second generation antipsychotic given as a long-acting injection, unless there are compelling reasons to the contrary. And even in cases where patients say they don't want an injection, the advantages of the long-acting injections are so great, we should be making strenuous efforts to educate and persuade patients that really this is very much in their best interests to have this as a treatment.
And what action should NICE be taking?
The current NICE guideline for the management of schizophrenia recommends that in both first and subsequent episodes of psychosis, treatment should be with oral antipsychotics and there's no preference expressed for either first or second generation agents. The guideline states that patients should be involved in the choice of which treatment they should be offered, and the side effect profile of the drug is the most important factor in determining treatment choice. Now, that was reasonable 10 years ago when the guideline was published. The current NICE guideline, in fact, goes back to 2014. The guideline has been overtaken by changes in our understanding of what a better approach to treatment would be. And if we take the current guideline as it stands currently, it's no longer fit for purpose. And my view is we need an urgent expert review to update the guideline, at least in respect of these recommendations.
What you're suggesting sounds simple, but putting it into practice is probably more complicated. What would a new approach to treatment actually look like?
I don't think it needs to be complicated. It's a quite simple process. The choice of antipsychotic should be limited to those which are available as a long-acting injection and second generation. So when seeing any patient, that is the presumptive treatment. Doesn't matter which one the patient is offered. If the patient accepts and they initially will respond to oral treatment, because you wouldn't start straight off with a long-acting injection, you would give oral treatment to start. If they respond to oral treatment, then you just continue on the long-acting injection, and it's as simple as that. If they don't respond to the first second generation drug given orally, then a second generation drug is given initially orally, and if the patient responds, then that then continues as the long-acting injection. If the patient fails 2 treatments, they should immediately be offered Clozapine. So this approach would not only improve outcomes in non-treatment resistant schizophrenia, it would also bring patients with treatment resistant schizophrenia into earlier accessibility for Clozapine, which would be very much to their benefit. I was involved a few years ago in a cost of illness study in schizophrenia in the UK. The mean cost of a single hospital admission with a psychotic relapse for a person with schizophrenia is £47,000.
Mental health services, of course, are under tremendous pressure. How would they be able to implement what you're suggesting?
I wouldn't suggest that they should try to implement it overnight. With first episode patients, the incidence of first episode is relatively low. So as new patients came into early intervention services, then this treatment approach could be implemented on a patient-by-patient basis, which wouldn't really stretch resources. For patients with chronic schizophrenia, there is a large-scale study within NHS populations which found that approximately 1 patient in 3 is admitted to hospital with an acute psychotic episode every year. So if, when those patients are admitted, the treatment plan involved discharge on a second generation long-acting injection, then we would be able to effectively cover the 100% of the population within 3 years. And again, it would not stretch resources.
You've told a very compelling story here. Could you just summarize it for us in 2 to 3 sentences?
In people with schizophrenia, the combination of the illness itself, suicide, lifestyle risk factors, physical comorbidity, and poor general physical health and poor physical health care contribute to a loss of life expectancy that is so great, it actually contravenes international conventions for the right to health. Now, it's not me who said that. that comes from an editorial which was written by Professor Graham Thornycroft at the Institute of Psychiatry in the British Journal of Psychiatry over a decade ago. To say this is a scandal is an understatement. The other side of the coin is that there is compelling evidence that second-generation antipsychotics given as long-acting injections can significantly reduce these mortality rates. If they became the presumptive first-line treatments for people with schizophrenia, there'd be a marked improvement in outcomes and a significant reduction in mortality rates. And the icing on the cake is that it would be astonishingly cost-effective.
Thank you. Now, I can't let you go without asking, for those who've been inspired by your example, what would you say to a young pharmacist who was wondering whether mental health is a field that they should consider specializing in?
I would recommend it. I would say at least give it a try. My own experience is I have thoroughly enjoyed working in mental health. I find the work interesting, challenging, involving, and rewarding. Pharmacists are welcomed as members of an extensive multidisciplinary team. And that's true in both acute and community settings. And roles for pharmacists as independent practitioners and as consultants are only going to increase. And I wouldn't work in any other specialty.
John Donoghue, thank you very much for talking to us about this fascinating and frankly concerning topic. For more information about John Donoghue's work, please visit the website using the link in the description, and be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.